Hello students, today's lecture is on scaphoid fractures, very important. So we'll be studying the scaphoid fractures under following headings: the anatomy, mechanism, injury, pathophysiology, diagnosis and clinical examination, classifications, treatment and complications. So starting with the anatomy of the carpal bones. So in total there are 8 carpal bones. Carpal bones are present in the wrist joint between the radius and ulna and the metacarpals. So in total there are 8 carpal bones and they are present in 2 rows. These 2 rows are proximal and the distal rows. Okay, so there are 8 carpal bones present in 2 rows, that is the proximal and the distal rows. Each rows consists of 4 bones. So they are scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate and hamate. So to remember this, there is a good mnemonic. Mnemonic is she looks too paranoid, try to catch her. For she, S for she is for scaphoid, then L is for lunate, T is for triquetrum, P is for pisiform, then again T is from trapezium, then T is from trapezoid, then C is for capitate and H is for hamate. This arrangement is from the radial to the ulnar side, that is from lateral to medial side. So scaphoid will be laterally placed and lunate will be medial to it, then triquetrum will be medial to it, and pisiform will be medial most in the proximal row. Similarly, trapezium will be on the lateral side, then trapezoid, capitate and hamate will be on the medial side, with hamate being the most medial most. You can see this here on this X-ray. This is scaphoid. Here is the scaphoid bone. This is the radial most. This is your radius. This is your ulna. So scaphoid is the most radial most in the proximal row. This is your proximal row. There are 4 bones: scaphoid, this is your lunate, this is your triquetral, and this is your pisiform, and this is your distal row. There are 4 bones. Lateralmost is trapezium, then you have the trapezoid, then you have the capitate, and the medialmost is the hamate. So there are 2 rows, each consisting of 4 bones, completed 8 bones. So coming to the scaphoid fractures, the word scaphoid is derived from the Greek word that is scaphos, meaning boat. Why is it called a scaphos or a scaphoid? Because it looks like a boat and it acts as a link between the proximal and the distal carpal rows. So you can see in this photo that scaphoid looks like a boat. Shape is like a boat, like this. So the scaphoid lies at the radial border of the proximal carpal row. So this is your scaphoid, the one marked in the orange color. So it is in the proximal row and it is at the radial border. This is your radius. So it is in the radial border. So scaphoid represents the floor of the anatomical snub box. The anatomical snub box is a very important anatomical structure. We will be looking what it is in the slides to come. One peculiarity about scaphoid bone is it is 80% of the surface is covered by the articular cartilage. What is the importance of this point? The importance is that articular cartilage may be damaged by screw insertion while doing surgery. So we have to be very vigilant about the screw insertion. It may pierce the articular surface and cause arthritis. As 80% is covered by articular surface, it is not covered by periosteum. So as periosteum is not there, there will be minimal callus formation after fracture. So there will be more chances of non-union. And as 80% is covered by articular cartilage, the entry site for blood supply, blood vessels is very limited. Therefore, there is more chances of avascular necrosis of this bone. So These are the peculiar points about articular cartilage covering 80% of the bone. Then coming to the next part of the anatomy, there are four parts of scaphoid. First is this tubercle, then we have the distal pole, then we have the waist here, and then the proximal pole. Proximal pole is like proximal part is towards the radius. So we have the these two are part of the distal part. Tubercle is also known as distal tubercle, and then we have the distal pole, then we have the waist, and we have the proximal pole. Waist is important because majority of the fractures occurs at this site. Then coming to the articular surfaces. Articular surfaces means articular surface is that surface which connects with other bones of to form a joint. So the scaphoid articulates with five bones, that is the radius, the trapezoid, the trapezium, the lunate, and the capitate. So the proximal surface that is towards the radius articulates with the radius, this part. So this part articulates with the radius. It's the proximal surface. Distal surface, it on the lateral part, it articulates with the trapezium and the trapezoid, this part. Medially, it articulates with the capitate, this part. And the ulnar surface articulates with the lunate. So this part articulates with the lunate. So it articulates with five bones. Then coming to the blood supply is very important because there are few peculiarities about the blood supply of the scaphoid bone. Blood supply is only by the radial artery. Radial artery gives two branches. One is the dorsal branch and one is the volar branch. Dorsal branch is the main blood supply. It supplies 70% of the blood supply, and the volar branch supplies the remaining 30%. There are few peculiarities about this blood supply, which we will see in the slide. See, as a majority of the articular surface is present on scaphoid, that is 70%, there is very limited site for this blood supply to enter the bone. It can only enter through ligamentous attachments or the bare surfaces. So the blood supply is very precarious in scaphoid bone. So the blood vessel to this bone enters the scaphoid distal to wrist joint. This is your wrist joint. So the blood supply has to enter distal to the wrist joint. So this configuration predisposes the fracture on the proximal aspect to aseptic necrosis or the avascular necrosis. See, this is your radial artery. It is giving two branches, the volar and the dorsal branch. Both are entering from distal to proximal. So the blood supply is retrograde. It is in the opposite direction. Normally the blood supply to a bone is anterograde, right, like this. But in scaphoid, due to articular surface, the blood supply is retrograde, that is in the opposite direction. Therefore, there is stasis of blood, and if there is a fracture at this part or the waist, this blood supply is cut completely, and the proximal part, that is this part, has no remaining blood supply. So this part undergoes a vascular necrosis. So scaphoid bone is one of the bones in the body which is very likely to get a vascular necrosis. Other bones are neck of femur, talus, and scaphoid is one of them. There is something known as a rule of 70 for scaphoid. 70% of all carpal fractures occur at scaphoid. 70% blood supply is supplied by the dorsal branch of radial artery. 70% of fractures occur at the west of the scaphoid, and 70% of the fractures unite. Uh, this means 30% of the fractures does not unite. So the non-union is nearly 30%. This is a very high number. 30% of the fractures of the scaphoid goes into non-union because of the precarious blood supply. And coming to the epidemiology, the scaphoid is the most commonly fractured carpal bone. Ages, though it can occur from 10 to 70, but the most common age is 20 to 30 years. This age group is more affected because it occurs in the people who are more active or younger age group. And scaphoid fractures are uncommon in children because the physis of the distal radius fails first. In children, the distal radius epiphysis is not fused. So when they have an injury at the wrist, the distal radial epiphysis fractures first and scaphoid is saved. It is more common in male, and about 5 to 12% of scaphoid fractures are associated with other fractures. 70 to 80% occurs at the west of the scaphoid. This is the rule of 70. And remaining 10 to 20% can occur at the proximal part. Then coming to the mechanism of injury, the most common mechanism of injury, there are two mechanisms of injuries. It can be hyperextension injury or a compression injury. But hyperextension injury is the most common, and compression injury is very rare. We can see in this, when a person falls with an outstretched hand. See, this hand is outstretched. When we see this mechanism of injury, it most commonly results in a scaphoid fracture. Fall on an outstretched hand, or we can see it here also. There is this hyperextension injury resulting in fracture of the scaphoid. And coming to the clinical features, there will be pain along the radial side of the wrist, and there will be inability or difficulty to move the wrist joint. And coming to signs, there will be swelling, there will be tenderness. Both will be present in the anatomical snub box. This is your anatomical snub box. It's a very important anatomical structure. We'll see it in the next slide. What does it mean? There will be tenderness with axial compression of the thumb towards the snub box, and the radial ulnar deviation will result in pain on the radial side of the wrist. And coming to anatomical snub box is present. It is also known as the radial fossa, and it is present on the lateral aspect of the dorsum of the hand. So this is your lateral aspect, and this is your dorsum. So here is your anatomical snub box. It is formed by the tendons of extensor pollicis brevis and abductor pollicis longus on the lateral side, and tendon of extensor pollicis longus on the medial side. And its floor is formed by the scaphoid bone. So the importance of this anatomical snub box is, as the floor is formed by the scaphoid bone, when there is a scaphoid fracture and we press in the anatomical snub box, there will be tenderness over the scaphoid bone. Then there are few provocative tests to diagnose scaphoid fractures. Those are scaphoid compression test, scaphoid tubercle tenderness, painful resistance pronation, and the Watson test. In a scaphoid compression test, the first metacarpal is compressed against the wrist. This is your first metacarpal. This is being compressed against the wrist. If there is a fracture of the scaphoid, the patient will complain of pain over the anatomical snub box or over the scaphoid bone. And this mostly denotes a scaphoid west fracture. And there is scaphoid tubercle tenderness. So this is done on the volar aspect. The physician extends the patient wrist with one hand and applies the pressure over tuberosity and the proximal west crease with the opposite hand. So physician is holding the hand in this part, and he is trying to extend the hand, and with other hand he is pressing over the scaphoid tubercle here. If there is a tenderness at this point, then it denotes a scaphoid fracture. So this scaphoid tubercle tenderness is more specific than tenderness at the anatomical snub box. So this is a very important test. Then if we try to pronate, pronation will be this moment. If we try to pronate the forearm of the patient, there will be pain over the scaphoid here, and will be here. Patient will complain of pain. Then there is a Watson test or a scaphoid shift test. So the examiner grasps the wrist of the patient with their thumb over the scaphoid tubercle. So with this hand, he is holding the scaphoid tubercle. The patient's wrist is then moved from ulnar to radial deviation. So this is ulnar. Your ulnar is in this part. So this hand is present in ulnar deviation. So as the examiner turns the hand towards radial deviation, then the examiner will feel a significant clunk and the patient will experience pain if the test is positive. So the examiner will feel a clunk over here, and the patient will also feel of pain. So if this is present, then this indicates a ligament injury, that is a scaphoid unit ligament disruption, along with the scaphoid fracture. So it's a very important test. Coming to the classifications, there are broadly 5 classifications. That there are more classifications than 5, but I have taken the ones that are more important. Those are the anatomic classification, Herbert classification, Roos classification, Mayo classification, AO classification. Anatomic classification is very simple. It's divided into proximal, middle, and a distal third. Middle is also known as a waist fracture. It's the most common fracture of scaphoid. So proximal third is 25%, middle third is 65%, remaining is distal third, that is 10%. Distal third is further divided into distal articular surface fracture and the distal tubercle fracture. Coming to Herbert classification, these are classified on the basis of stability of the fracture and the status of the union. So on the basis of stability, he classified the fracture into stable and unstable type. We say the fracture is unstable when there is more than 1 millimeter displacement over the fracture site, or an angulation of over 5 degrees. Okay. So on the basis of these two criteria, he divided the fractures into 4 types: type A, B, C, and D. So in type A, it is a stable fracture and acute type. Acute means a fresh injury. In type B, it will be acute fracture with unstable type. Unstable means there will be more than 1 millimeter of displacement of the fracture site. Type 3 is delayed union. So it's not a fresh fracture, but a old fracture which is not uniting in the given time frame. In type 4, there will be established non-union. It will be a old fracture and there will be no union after for 6 to 9 months. So type A, B, C, and D are based on the basis of stability and union. There is Roos classification. It's very simple. It's based on the inclination of the fracture line. So it can either be horizontal, can be a transverse fracture, or it can be a vertical oblique fracture. Then Mayo classification is similar to the anatomic classification. So there are 3 types: type 1, 2, and 3. Type 1 is proximal third, type 2 is middle third, and type 3 is distal third. And type 3 is divided into type 3A and type 3B, that is distal articular and distal tubercle. So it's very similar to the anatomic classification. Then AO classification, it's not very important, it's just for documentation purposes. Then coming to this investigation. So when you suspect a scaphoid fracture, the first thing you do is an X-ray or a radiograph. A radiogram, it can be done in 4 ways. It can either be a posterior anterior view, it can be a lateral view, it can be a scaphoid view, and it can be oblique views. If the X-rays are not able to confirm the diagnosis, because what happens is in 20 to 25% of the scaphoid fractures, on initial X-ray we don't see any fracture. Even though the fracture is present, in 25% we don't see any fracture. So X-ray has to be repeated after 1 to 2 weeks when the fracture is more visible. So when the patient comes to you, you diagnose clinically a scaphoid fracture, but the X-ray doesn't show any fracture. We are supposed to repeat the X-ray after 1 to 2 weeks. And if X-ray doesn't show any fractures and we have to confirm it on the first day only, then a CT scan is a good option. We can also do an MRI scan, or we can do an isotope scan. So coming to the scaphoid view. Scaphoid view is a posterior anterior view of the wrist with the wrist in ulnar deviation. So if we see, this is your ulna is in this part, so the wrist is deviated ulnarwards. What is the advantage of this? It displaces other carpal bones and the scaphoid is more clearly visible, as we can see here. So it is more sensitive to diagnose scaphoid fractures. CT scans as indicated when a suspected fractures with inconclusive evidence on X-rays. We can do MRI scan It is indicated to rule out avascular necrosis of proximal pole of the scaphoid in neglected fractures. See, in this MRI, this is your scaphoid bone, and we can see that this part has gone hypodense. So because this is looking hypodense, this is diagnosed as avascular necrosis. This part has no blood supply, so this is dead. So this appears separate from the distal part. So MRI is useful for diagnosing the avascular necrosis of the proximal pole. Then we can do isotope scan. In isotope scan, it is also known as a bone scan, or we can also do a PET scan. So this will show increased uptake of the radioisotope or the dye. So these are known as hotspots. When a fracture occurs, the bone activity for union increases. That's why the isotope is more absorbed, and it shows a hotspot on an isotope scan. Then coming to the treatment. So treatment is very simple. If it's an undisplaced fracture, then we give a scaphoid cast for 8 weeks. If it unites, then we remove the cast and send the patient for physiotherapy, that is wrist joint movements. If it doesn't unite in 8 weeks and it's going towards non-union, then we treat it as a non-union. Okay. So if it's a displaced fracture, that is there is a more than 1 millimeter of displacement, then we try to reduce the fracture. We take the patient to the operation theater and we try to reduce it under C-arm guidance with close reduction. If the reduction is okay, we put percutaneous pins, that is K wires. And apply a plaster of Paris plast. If it unites in 8 weeks, then we send the patient for physiotherapy. If it doesn't unite, then we treat it as a non-union. And if the reduction is not okay inside X-ray, then we do the open reduction and internal fixation of the fracture with either K wires, Herbert screw, or cannulated screws. If it unites, again the same, then we send the patient for physiotherapy. If it doesn't unite, then we treat it as a non-union. So the treatment of non-union is open reduction, bone grafting. We take a cancellous bone graft or a cortical cancellous bone graft from iliac crest, and we fix it with Herbert screws. So the treatment of non-union, open reduction, bone grafting, and fixation with Herbert screws. Then the conservative management, this it is done by a scaphoid cast. Scaphoid cast is a very specific cast in which the hand is held with cast in a glass holding position. It is kept like we hold a glass in the hand. So the cast is applied with radial deviation. So the cast is in radial deviation with 10 degrees of dorsiflexion. So it's in 10 degrees of dorsiflexion, and the thumb is forward. You can see here the thumb is forward. So it's like we are holding a glass in our hand. So this is applied for 8 weeks and then removed and followed by physiotherapy. And Herbert screw is a peculiar screw or a different type of screw which is used in scaphoid bone fractures. You can see in this X-ray, this is fixed with a Herbert screw. So Herbert screws are headless screws. They don't have a head. What is the advantage of this? As 80% of the bone is articular cartilage, or is articulating with other bones, we can insert this screw inside the bone, as this it doesn't have any head, and this has different pitch. Pitch is known as distance between adjacent threads of a screw. So the Herbert screw is a variable pitch cannulated screw. It is also called as a headless compression screw and is used to achieve interfragmentary compression through its differential pitch. It is Herbert screw can also be used in scaphoid, capitulum, and radial head, or any osteochondral fractures. And coming to the complications, there can be complications like avascular necrosis, non-union osteoarthritis of wrist, and malunion. Actually, this avascular necrosis and non-union of scaphoid fracture are separate topics, so we'll be taking it in different lectures. Thank you very much.